Should be able to see my screen now. Okay, so we will get started. So thank you to all the organizers for putting together this wonderful webinar series. I think one upside of the pandemic has been these amazing Zoom symposiums that have come up, and we have now such incredible educational resources on the internet at a fingertip. Particular thanks to Dr. Chauhan and who's been the director of NOWS for the past 2 years and has put this great team together. My talk cannot start without paying some homage to this amazing man, a pioneer and a visionary in Pakistan, who's truly revolutionized how neurosurgical training now happens in Pakistan, and his vision of um, educating medical students and residents and people in the field about neuroscience is exemplary. And he, to me, is a great mentor and a friend and a father figure. And I owe a lot to him as my journey has extended in neurosurgery. I don't see him here. I wish he was here, but hopefully he'll see this recorded. So I don't have any disclosures. These are the objectives. We'll try to get through quickly. There's a few slides that we need to get through, and then we'll have a nice discussion at the end. So as Fatma mentioned, I started at AKU almost 2 decades ago now, and had great mentors throughout. These pictures are from over 10 years ago. First neurosurgical operation I ever saw was a selective amygdala hippocamectomy in a young woman at AKU. And it was Dr. Athar Anam and a neurosurgeon from the US, whom I found out several years later was Dr. Warren Bowling. And I had no idea at that time that he, in fact, trained at the University of Kentucky, did fellowship in Montreal, and then was in a nearby hospital in Louisville for many years. But I recently had the chance to meet him. So my interest in epilepsy surgery started pretty early, and I don't exactly know why, but I suppose it was the experiences I had during med school and then during my rotations, and then residency at University of Kentucky, and then fellowship in Montreal. So this picture, I almost always show this. This is Wilder Penfield's OR in Montreal from the early 1900s. And you can see Dr. Herbert Jasper in the background reading a paper EEG, and Dr. Penfield is in the center. Patient's awake. The anesthesiologist is holding the patient's hand, and they're doing an awake operation for for epilepsy. And being in Montreal at the MNI, this was OR1, and we used to be there every day operating and doing very similar cases that were being done almost 100 years ago now. Again, during residency and fellowship, I had some incredible mentors who really shaped the way I think about neurosurgical disease, and particularly epilepsy and brain tumors. During residency, I got to see several epilepsy surgery operations, participated in many different types, but the fellowship was truly a transformative experience for me, where I learned the SEEG methodology, understanding a very methodical pre-surgical evaluation of a refractory patient, nuanced approach to each patient, and then also programmatic development. What I took away the most from that whole experience, that epilepsy surgery is truly a unique subspecialty within neurosurgery, where you have several tools at your disposal and many different types of operations that you can do for patients who are suffering from this disease. What I also realized more so in the last 3 years, that as a cranial surgeon or an epilepsy surgeon or a brain tumor surgeon, you're truly straddling these two specialties, and they go hand in hand. And you'll see a lot of patients who have brain tumors who also have seizures, and people who have refractory epilepsy who also have brain tumors, and vice versa. So it's important to think of yourself, and this is particularly for residents, that you're not just treating brain tumors, but you're also treating the manifestations of those brain tumors. So let's start with an example. This is a patient with a very large brain tumor. And really the decision-making, or the decision tree in this case, is, does the tumor need to be treated? The answer is yes. And if yes, what is the safest approach or technique that you should use to treat this? And then based on pathology, you just decide the treatment strategy. Tumor surgeon, patient, and family are those that are involved in this decision making. You proceed with the operation, you do a resection, patient does well, gets neoadjuvant chemotherapy, 3 years out, doing fine. On the other hand, when you take a patient with refractory epilepsy, the decision tree suddenly explodes into a very intricate um, algorithm where you have a medically refractory patient. The goal for that patient, for us, is to get them to an improved quality of life, either via seizure freedom or reduction in seizure burden. To do that, you have to go through multiple steps along with a multidisciplinary team and then decide what kind of intervention would be appropriate for that patient. And that can't be done without a large team who's backing you at every step and is participating in the care of these refractory patients. So we have our epileptologists, we have our neuropathologist, our research team, our EEG techs, who are absolutely essential to this mission. And then our neuropsychologists, neuroradiologists, again, without whose expertise this simply can't be done properly. So before we jump into the actual meat of the talk, which will be long-term epilepsy-associated tumors, anybody who has refractory epilepsy at our center, at least, and across many other centers in the world, some basic testing is considered. So epilepsy monitoring unit with video EEG, high quality MRI, which is read by an epilepsy trained radiologist, functional imaging in the form of PET scan, neurocognitive testing, that has become basic testing for our refractory patients. And then based on findings from these studies, then we embark on secondary testing if it becomes necessary. And the important thing in this process is that the epilepsy surgeon should be meeting the patient or be involved in this decision making from the get-go, rather than everything is done, patient has been determined to be a surgical candidate, and then they're being introduced to the epilepsy surgeon. And there's some reasons that we will discuss later why that is important and changes patients and physicians' perception about epilepsy. So the basic data, we take it to our refractory epilepsy conference. We meet every week, every Friday. We discuss the patient in depth sometimes for over an hour at a time. And if the data is concordant, then we consider surgical options. And if discordant data, then we embark on further testing, which could be in the form of these studies and beyond. Once surgery is done, then we keep a close follow-up on these patients. And this also includes neurocognitive testing, which is done baseline pre-op, then 1 year, 2 years, and 5 years post-op to assess long-term effects of the treatment itself and the cure of epilepsy on these patients. This is an algorithm that we have generated over time and won't continue. So just thinking about refractory epilepsy is one of the most common neurological disorders around the world, and in low and middle income countries, the disease burden is higher, treatment resources are limited. Particularly in children, at least in the United States, this is the second most common and the costliest in healthcare utilization, with its adverse impact on children's academic and health outcomes. So what is drug-resistant epilepsy? It's a failure of adequate trials of two well-tolerated and appropriately chosen medications, which do not lead to a sustained seizure freedom. Early identification, it's intuitive. It's important to identify patients early on before or as they become refractory, as we know that refractory epilepsy has significant effects, not only on the brain, but also on the psychosocial, physical aspects of patients' well-being. In children, in particular, brain development can be severely affected, leading to increasing cognitive handicaps over time. And this could be from ongoing seizures, side effects from multiple medications, or just a social stigma, not being able to drive, not being able to attend school, not being able to have a job, etc. And one can only imagine how much worse this is in a resource-limited setting where basic medical needs aren't met. So to quickly recap surgical procedures and indications, the way I like to think about this: diagnostic and therapeutic surgical interventions. So their diagnostic would be in the form of stereo EEG or subdural grids and strips to diagnose the onset of a seizure network or the seizure. Therapeutic operations can be thought of with what is your intended outcome from the operation? Are you aiming to make the patient seizure free, or are you aiming to improve the quality of life by reducing seizure burden and reducing the intensity and frequency of seizures? And in one way or the other, all epilepsy surgery is palliative, and palliative here does not mean end of life care, but rather improvement in quality of life, with the ideal goal being seizure freedom, realistic goal being significantly improved quality of life with reduction in medication. One can also think of therapeutic operations in the form of the technique that is utilized. So resection of a seizure focus or ablation of a seizure focus with radiofrequency or laser, disconnection of an epileptogenic zone, or neuromodulation, as we were talking about a few minutes ago with RNS, DBS, or VNS. And then something that has become an interest of mine is the timing of intervention, particularly for patients who are presenting with acute refractory status epilepsy. So putting all these different operative options that we have, and this is a slide that I've slowly populated over the years and keep expanding on this, but it's a spectrum. Neuromodulation falls on more the palliative spectrum, where patients likely will not be seizure free, but will have improvement in their quality of life. Whereas resections, disconnections can be more of a curative nature. We know that the best response to surgery for refractory epilepsy is usually with lesional or MRI positive epilepsy. So hemispheric epilepsy, focal cortical dysplasias, temporal lobe epilepsy with mesial temporal sclerosis, cavernomas, AVMs, and tumor-related epilepsy often responds the best to surgical intervention. So in the realm of lesional epilepsies, which again is a term that I don't quite agree with, but time for maybe perhaps a different talk at a different time. But epileptogenic substrates in the form of long-term epilepsy-associated tumors will be the focus of our talk today. So what are LEATs or LEATS or long-term epilepsy-associated tumors? This term encompasses lesions which are identified in patients who are being investigated for long-term history of epilepsy or refractory epilepsy. These are generally slow-growing, low-grade, cortically based tumors, often arising in younger age groups, and in many cases exhibit on pathology neuronal and glial differentiation. And they often have temporal lobe predominance. Gangliogliomas, DNETs are the predominant in this group. And then they can often be associated with focal cortical dysplasias, which if you don't have the right kind of MRI, you might miss that, but almost always these have some sort of dysplastic tissue adjacent to them. And in the recent FCD, focal cortical dysplasia classification, these have been grouped as type 3Bs, where you have an FCD and you have a LEAT associated with it. And in most of these cases, surgical treatment is beneficial for managing seizures as well as the tumor. And in very few cases, these tumors may show regrowth or recurrence, and if left alone, they may undergo anaplastic progression, but that is incredibly uncommon. Some different types of tumors that fall under this category. So how does epileptogenesis occur in these? So these could be purely tumor-related factors. So these are dysplastic neurons, high neuronal component with hyperexcitability, higher expression of glutamate receptors, altered expression of gap junction channels and inflammatory interleukins. All of this contributes to the tumor itself being epileptogenic, as opposed to, for example, if you have a cavernoma, the cavernoma itself isn't epileptogenic, but repeated bleeding and hemosiderin deposition around it would irritate the brain tissue around, leading to the pericavernoma tissue becoming epileptogenic. So associated hippocampal sclerosis and FCD, as we talked about. And then if you have epilepsy for a very long duration, 20, 30 years, then you're establishing these wide networks kindling phenomenon of other parts of the brain, and you start having multiple foci beyond the origin of the seizure. So back to that slide that we looked at. You have a tumor and the patient comes in, there's a tumor on the MRI, and the decision needs to be made what to do. And at this point, when you have somebody with a tumor and seizures or refractory seizures, there should be more nuanced thinking before you embark on resecting that tumor. So the way I like to think about it is the tumor being removed, or does the tumor need to be treated for pure oncological, or does the tumor need to be removed for a combination of oncologic purpose and epilepsy control? Or is this a very benign looking tumor which is acting as the epileptogenic substrate, and surgery is being considered purely for control of epilepsy? Let's consider the first category. So these would be straightforward, um, right in your face kind of lesions. So metastatic lesions, GBMs, meningiomas, which are presenting with symptoms and need to be treated. So all of these different kinds of tumors would fall in that category: large meningiomas, infantile hemispheric tumors, acoustics, posterior masses, etc. Second group of tumors would be that they have a diagnosis of epilepsy and the tumor has concerning radiographic appearance. So generally, these are these DNETs, gangliomas, or they are these grade 1 or 2 astrocytomas. And in these patients, you need to do an operation to not only address the oncologic aspect of the tumor, but also address the patient's epilepsy or refractory seizures at the same time. And in these patients, our goal is to at least do some basic workup to understand the epileptogenic zone, neurocognitive functioning, and include some function testing in the form of function MRI. And then decide if we need to go beyond the margins of the tumor or do intraoperative ECOG, or consider some form of extraoperative mapping in the form of SEED before we resect. These tumors, however, are usually low-grade gliomas. So you can see this posterior cingulate glioma, which clearly looks like a grade 2 glioma on imaging and was confirmed on PATH as well. This was a patient presenting with cingulate type seizures. This is a patient with a pan-hippocampal, right-sided pan-hippocampal infiltrated glioma, again, presented with seizures, being treated for seizures, found to have this imaging. Imaging is concerning that this could be a higher grade lesion. It turns out that this was a grade 2 lesion, but with molecular markers considered high grade 2. Another important thing to consider, in sort of a side note, that seizures and gliomas, particularly in low-grade gliomas, they're synergistic to each other. And there's compelling evidence now that is coming out that ongoing seizures actually promote glioma growth through the same mechanism, which is disrupted potassium handling due to genetic mutations within the tumors. And this is quite interesting, that if you have a patient with a low-grade glioma and you've done an operation and they're still seizing, this may not portend a good prognosis. On the contrary, there are some interesting studies which are showing that people who have low-grade gliomas and have seizures, they actually do well in the long run. So there's conflicting data, but more evidence to support that glioma proliferation and progression may be interlinked with ongoing seizures. So it would be useful to consider gliomas as an epileptogenic lesion and treat them more, not only just from an oncologic perspective, but also from an epilepsy perspective. So here's another young girl. She was 16 when she presented, had seizures for 2 years, has this large posterior parahippocampal lesion based on the tentorium, was having seizures almost daily. Again, this tumor was concerning that this could be a high-grade lesion. So again, the intent of operating on this patient was both epilepsy and oncologic control of the tumor. Thankfully, this turned out to be a grade 1 PXA. So the patient is now 2 years out, is married, has a kid, and is doing well in the seizure. This is another patient
Wait,
who
Farhan, can you go back to the previous slide? Do you think this is in the hippocampus?
no, it's perihippocampus, posterior perihippocampus, and it was pushing
Okay.
the hippocampus. So you can see the hippocampus right here.
Yeah.
Yeah.
Yeah, I'm sorry. I
So
thought you said it was involving the posterior hippocampus. Maybe I misheard. Sorry.
sorry, posterior perihippocampus, posterior temporal lobe
Okay, got it,
perihippocampus.
got it,
Yeah, yeah.
got it, got it.
It's more towards the isthmus of the cingulum. No, sorry, isthmus of fusiform gyrus, perihippocampic gyrus going in towards the isthmus of the cingulum. But no, the hippocampus itself is spared, and nothing had to be done for that. This is a patient with 2-3 years of seizures, somehow was never imaged and was eventually imaged and found to have this large temporal fossa meningioma. And in her case, we were concerned that the epileptogenic zone would be obviously beyond the margins of the tumor and the perilesional temporal lobe. So she underwent a full workup, and we decided to perform not an extended resection of the temporal lobe, but at least take the hippocampal head out along with this affected perilesional tissue. So third category, and probably the important one that we are focusing on today, is patients who have a diagnosis of epilepsy, are refractory to treatment, and have tumors that are benign and have a benign radiographic appearance. So 4 different patients, and all of them have some findings. So this first image on the left, there's this little hyperintensity that we've just been following for a long time and has not evolved or changed, and the patient's seizures are well controlled. This patient with this anterior cingulate hyperintensity, 2 patients with amygdala hyperintensity. All of these are likely low-grade tumors of some sort, but patients are well controlled on medication, on a single medication, not having seizures, and these are tumors that have been followed. This is a patient who has this odd-looking lesion in the left frontal operculum, has events, but then on workup, they were classified as non-epileptic. So again, something that we haven't touched. Now, this is a young boy who's had seizures since he was 5 years old. He's well controlled on 2 medications. Family and the patient themselves, they're resistant to the idea of surgery, but truly this is either a ganglioglioma or a DNET, again, of the posterior perihippocampus adjacent to the tail of the hippocampus right here. And one could argue that operating on this could portend seizure freedom and a long-term better outcome for this patient. But again, family wishes, you have to entertain those. On this note, and this patient also had generalized findings on scalp EEG, which when you discuss with your epileptologists, they would be very hesitant when they see generalized findings with a lesion, and it doesn't corroborate that this is truly the seizure onset, this lesion itself. There's good studies to suggest that young brains, if you have seizures starting in early childhood with an associated lesion, oftentimes the networks are so wide and so strong that they start mimicking generalized EEG findings, generalized epilepsy on scalp EEG. So it's important not to dismiss patients as generalized epilepsy when they have a true epileptogenic lesion on the MRI. So this is another patient. He has this fusiform gyrus, posterior fusiform gyrus lesion. He was relatively well controlled on medication, but was having side effects from his medication. So mood issues, anger, drowsiness, sleepiness. So again, he went complete workup. He underwent resection through a simple keyhole sort of craniotomy. And he is now 2 years out of medication, side effects are resolved, and he remains seizure-free. So one of these cases is that in some people, some children, some adults, you do have to consider intervening if you're having side effects from medication, even though you may be well controlled with 1 or 2 and be seizure-free. This is another example of a similar story, a young lady in her 20s who, again, having side effects from the 2 medications she was on, has a clear amygdala lesion, which turned out to be a new WHO diagnosis of what's called NP, or uh, theomorphic tumor of the young, something like that, along those lines. Then we have this young boy, and it's interesting because he's had this lesion on his imaging for a while, and parents were resistant to the idea of surgery. And on further investigation with better MRI scans, if you can see my mouse on the right-hand side of the screen, you can see this white hyperintense signal here, which is a transmantle sign extending from the base of a sulcus to the ventricular ependymum, which converted this case from just a lesional case to a true focal cortical dysplasia associated with a tumor. Finally, this patient underwent surgical resection. In this case, we decided to do intraoperative ECOG to map out the margins of the tumor. You can see the subtle cortical changes over here on the right-hand side of the screen. Intraop corticography was done, resection was performed, and then patient is almost 3 years out of surgery, seizure-free, off meds. He was labeled as autistic before and ADHD. All of that has resolved, and he's now on the honors list. And two more cases of these similar tumors. So one, and this is a lady in her 50s now with almost 30 years of epilepsy, who has a known diagnosis of this posterior parahippocampal lesion right next to the hippocampus itself. The hippocampus is not infiltrated, but on the MRI scan, you can see it's hyper intense. And this is apparent because she has many seizures a week. So focal unaware events happening weekly. She underwent intracranial EEG, particularly because she had a long duration of epilepsy. Scalp EEG was showing seizures concerning from onset on both sides of the brain, or at least having interictals on the left side as well. So we embarked on SEEG, intracranial exploration, with a bilateral temporal implantation. And upon those findings, we decided to then proceed with a temporal lobe resection with resection of the amygdala, hippocampus, and the lesion itself. This was just a couple of weeks ago, so we don't have long-term data or imaging on this, but this was an example of somebody with long duration of epilepsy who needed an extensive investigation to delineate the margins of resection and also understand the involvement of the amygdala and hippocampus. This is another example of a young boy with what appears to be a contrast-enhancing lesion in the right temporal pole, but on further imaging, you can see that the entire superior temporal gyrus, as well as Heschel's gyrus, insula, there's significant involvement of all these structures, and this was concerning for focal cortical dysplasia, at least on imaging. On this patient as well, we embarked on an SEEG to understand the extent of resection beyond the tumor itself. And using those findings on SEEG, we decided to proceed with an extended temporal lobe resection with resection of the tumor. And perhaps on this middle image, you can see the tumor apparent on the temporal pole itself. So one side note, that if you're only looking for MTS or hippocampal sclerosis on MRI scan when you're thinking of or when you're evaluating a patient with refractory epilepsy, you will often miss out on a lot of these other important findings. So the eye doesn't see what the mind doesn't know. When you have a refractory epilepsy patient, you should be thinking if any of these other abnormalities exist, even in the setting of a tumor. Unfortunately, the most common scenario that we see here and around the world, that a patient undergoes a very regular brain MRI, which gets read as negative for MTS, because that is the most common thing that everybody's looking for. To me, that's an inadequately obtained MRI, which is not read by an epilepsy radiologist. Patient is often labeled non-lesional, non-surgical for the rest of their life. Unless they get treated with medication, or maybe they get a VNS, and further treatment for surgical workup is never even considered. The appropriate method, in my opinion, is a high-quality brain MRI read by a dedicated epilepsy radiologist, nuclear imaging read by a dedicated epilepsy radiologist, and then discussion of these findings in a multidisciplinary setting. And in our experience, often patients who had been labeled as MRI negative before we found lesions that were truly. So to summarize this thought, a proper epilepsy MRI read and post-processed by a proper epilepsy radiologist, that should be the aim in these refractory. Another question that comes to mind when you have patients like this, that should we wait until epilepsy becomes refractory to medical management? It's conflicting data, and there's a debate around this. There are people who are pro early intervention. There are physicians who are against the idea of early intervention and would rather have the patient become refractory. I think there's merit to both arguments. But the important thing is that anybody who has seizures ongoing for a prolonged period of time and are on medications should be evaluated at a higher level center, which can offer multiple different modalities for people. This is particularly important in children, as effective treatment can significantly reduce not only healthcare utilization, but the impact of multiple hospital visits on the child and the patient's family themselves. Another thing to consider, is it important to intervene early? Is it important to intervene early in the duration of the epilepsy and also in early childhood? And again, this is particularly important in younger patients who have focal epilepsies associated with these long-term epilepsy-associated tumors, and complete resection of the lesion, a shorter duration of epilepsy, and younger age at time of surgery all have shown to be beneficial with long-term seizure freedom. So some of the misconceptions that are sort of over the years collected about epilepsy surgery, and I've been asked these questions. A general surgeon asked me, wasn't this in vogue in the 70s? An internist asked me a couple of years ago, oh, so is this a new treatment that wasn't available before? Patients often come and say, oh, nobody ever mentioned this to me before. Or it was mentioned, but I was told I would lose my memory. My head would be shaved, I'll not be able to see again, etc. All these misconceptions or misconstrued thoughts are prevalent around the treatment of refractory epilepsy. So these are some of the myths that we have to dispel as neurosurgeons, as neurologists, as epilepsy specialists, that surgery for these cases is not dangerous. It is proven that surgery in well-selected patients is better than medical therapy. Healthcare costs and healthcare utilization is much better, but we don't know if this is true for low-middle income countries. It is also not true that waiting until the child is older is it safer. The sooner, the better. And we know that early intervention not only allows periods of brain development, which otherwise would simply not be possible with ongoing seizures, but it also allows children and young adults to achieve milestones and have higher gains in cognition from cessation of medications, and allow brain plasticity to help with recovery after an operation. The important thing to remember that cure is not always the goal. Epilepsy is a chronic disease, like heart disease, like cerebrovascular disease, asthma. That even if cure cannot be achieved, improving the quality of life within the time frame of the intervention should be the goal. And even if there's a low chance of cure, we should strive to treat these refractory epilepsy patients to improve their quality of life. And the goal is truly best treatment of refractory epilepsy and not medications versus surgery or neuromodulation versus resection. Early evaluation at a comprehensive epilepsy center is important, and proper testing is absolutely essential. And combination therapy is key. You can't just treat with medication or just treat with surgery or just treat with dietary changes. All has to happen in. And you have to utilize the resources that are available to you, which will vary from setting to setting, which will vary from centers within the United States to those in England or those in Europe, and of course in Pakistan and India. Particularly in a low middle income country setting, the goal right now as a group that we have started thinking of is how can we identify the disease burden in Pakistan? How do we identify knowledge gaps and gaps in awareness of these treatment options? And then work on building capacity, training experts in the field, making these basic tests available to patients and physicians in these low and middle income countries. So slowly this group is coming together. Particularly Dr. Sakib Bakshi has taken a leading role in this from AKU under the auspices of Dr. Inam's leadership. And we've had some posters presented at international conferences with other ongoing projects that are in the pipeline. In summary, tumors and epilepsy, as neurosurgeons and as neurologists, we should always think, what is the goal of treatment? Why are we planning to treat this tumor? And when you see a patient with epilepsy and brain tumor, think of that primary goal. Is it epilepsy control only? Is it oncologic? Is it both? If it is not purely oncologic control, then control of epilepsy should be one of the desired outcomes. And a proper pre-surgical evaluation should be considered before you proceed with simply resection of the tumors. Long-term epilepsy-associated tumor, particularly in children, there should be some consideration for early intervention, and that may portend a better long-term seizure freedom rate. It would have an impact on cognitive development, and despite the sort of long natural history of LEATs, waiting may not be the optimal choice, as that can preclude children from being able to achieve their full physical, cognitive, and social development. So with that, I would like to finish. I was last time in AKU was 2020, winter of 2020. It was beautiful, as always. And I got to spend time with a lot of friends, with Dr. Anam up here in the corner, operating in the true master surgeon fashion. I got to interact with a lot of students, which was very special, and made some long-lasting friendships and contacts. This is my daughter in the middle, who is clearly very happy to be there carrying her alumni. So with that, I thank you all for your attention and for taking out time while India and Pakistan are playing. And I think we're right on the dot with 40 minutes, and I'm happy to take questions.